Good morning. Welcome to the CU session on critical appraisal sessions. A couple of months ago, we were doing a series of diagnostic test accuracy study critical appraisals. And in one of those sessions, we had taken you through Quadas 2 checklist. And during the same session, it was informed that the Quadas 3 checklist is being developed and it may get published soon. And now that it has been published, we thought we'll take that opportunity to present a critical appraisal of a diagnostic test accuracy study using the Quadas 3 checklist to assess the risk of bias. And I'm pleased to hand over to Dr. Joseph Liyaskar, Consultant General Medicine and Clinical Epidemiology Unit, to take you through that session. And we'll open the session for questions at the end of the talk, either by unmuting yourself and asking your questions or by putting your questions in the chat box. I'll hand over to Dr. Joseph. Thank you.
Thank you, sir. In today's CU session, today we'll be doing a critical appraisal of a diagnostic accuracy study using the Quadas 3 checklist. So before we go into the critical appraisal, I would like to put forward two different clinical scenarios. The first scenario being a 45-year-old woman who has come to a TB screening camp. She is completely asymptomatic and she is HIV negative. Whereas the other scenario is a 55-year-old gentleman admitted to the hospital with 3 months history of fever, night sweats, loss of weight, and loss of appetite, and he is found to be retrovirus positive. So in these two different scenarios, the question we would be looking an answer for is, can a computer-aided detection software that reads chest X-rays be used for TB screening in these two different patients? So to find answer to the question, I looked up at articles, and the article that I have chosen for today's critical appraisal has been published in Lancet in December 2025. It is a cross-sectional diagnostic accuracy study which assesses the role of a computer-aided detection threshold for chest X-ray based tuberculosis screening. This study has been done in Uganda. And I'll be critically appraising this article using the Quadas 3 checklist. The Quadas stands for Quality Assessment of Diagnostic Accuracy Studies, and the previous version was Quadas 2, which was published in 2011. The updated version has been published in February 2026. The Quadas 3 checklist has 6 different phases, which we'll be looking in detail. The first phase involves statement of the systematic review synthesis questions. The phase 2, this is a new phase which has been introduced in Quadas 3, which requires us to describe the ideal test accuracy design for each of the synthesis question. Phase 3 requires us to plot a flow diagram of the study, and phase 4 involves identifying the accuracy estimate for each of the individual question, and phase 5 involves assessment of risk of bias and applicability concerns for each of the review question, and phase 6 gives an overall judgment for the trial. Under phase 5, we have 4 different domains which include participants, index test, target condition, and analysis. And there are multiple signaling questions which will be answered as yes, probably no, no, and no information based on the details provided in the study. And there are also 3 of the 4 domains which include participants, index test, and target condition will also be assessed for applicability. Compared to the Quadas 2 checklist, the Quadas 3 checklist has additional answering options for each of the signaling questions, which includes a probably yes and a probably no, which was not there in the Quadas 2 checklist. What has changed in the Quadas 3 checklist? There are some structural changes made. Like, for example, instead of assessing the study as a whole, here we will be giving an assessment of the risk of bias and applicability concern for each of the estimate level rather than the whole study. And there's a new concept called introduction of the ideal test accuracy trial, which was not there in the Quadas 2 checklist. There are also subtle changes to the domain names. Like, for example, reference standard has been renamed to target condition, flow and timing has been changed to analysis, and there are additional signaling answers available, which includes probably yes and probably no, which was not there previously. So this is one example from a Cochrane review where they have assessed the risk of bias using the Quadas 2 checklist, where the individual studies have been assessed in terms of patient selection, index test, reference standard, flow and timing. And they have also been assessed for applicability concerns in domains of patient selection, index test, and reference standard. And this is the previous Quadas 2 checklist which was used. And we'll be now looking into the Quadas 3 checklist. Here we could see the Quadas 2 was answered as either yes, no, or unclear, whereas now we have additional options which include probably yes and a probably no also. So before going into the critical appraisal, I just wanted to highlight about the WHO recommendations for an ideal screening test for tuberculosis. The WHO in its target product profiles for tuberculosis screening test states that for a high sensitivity screening test, it should have a minimal accuracy, diagnostic accuracy, having a 90% sensitivity and at least 60% specificity to be called as an ideal screening test for tuberculosis. And the software in question that will be analyzed in this current article is called as the QXR software, which is an AI-based software which interprets portable X-rays. And based on it, it gives a cumulative score which ranges between 0 to 1. The manufacturer recommended threshold for interpreting the chest X-ray as positive for tuberculosis is 0.5. Whereas in this study, in this Lancet study, the authors have initially used a cutoff of 0.5, but subsequently, after the initial 4 months, they've changed the cutoff to 0.1. The reasons that they have given for changing the cutoff to 0.1 is that multiple other studies done in South Africa had shown that uh, the sensitivity improved when the threshold cutoff was lowered down. And, and they had also noted that those who had a score between 0.1 to 0.5, they still had a 1% chance of being expert positive. So to not miss those cases, they would use a lower threshold of 0.1. This QXR-based software is also now being used in multiple hospitals in India, including mission hospitals in Orissa, and also now it's been used in clinical practice. Sorry, in service for patient care, they have already started using in multiple hospitals. So going into the critical appraisal, phase 1 involves us to state the systematic review synthesis questions. This is the individual, I will be going into the individual study SPICOT statement. The population chosen in this study were adults or adolescents aged 15 years or older who are not on active TB treatment, and regardless of patient's symptoms, they were included in the study. The index test was chest X-ray interpreted by the QXR software version 3.2, and the outcome being given as a continuous range between 0 to 1. And a score of more than 0.1 being taken as positive for tuberculosis. The reference standard used was an expert ultra testing of expectorated sputum, and the target condition in question was pulmonary tuberculosis. The study was done over a period of 22 months between June 2022 to March 2024. The primary outcome they looked for was the diagnostic accuracy of chest X-ray screening with computer-aided detection and stratification of thresholds based on age and sex. This was a community-based screening test. And next, coming to phase 2, which is a new component in the Quadas 3 checklist, which requires us to state the ideal test accuracy trial for each of the synthesis question. The study has given a proforma for what would be an ideal test accuracy trial. An ideal test accuracy trial, there should be a clear-cut objective for the trial. The participants should have been prospectively enrolled, either consecutively or at random. The participant should be representative of the intended use population, and details of symptoms and prior test results should be reported. And with regards to the index test, appropriate technical version should be used, and it should be carried out as per the recommended instructions. The interpretation should not be affected by external information or based on the reference standard, and it should have a predefined threshold. And with regards to the target condition of the reference standard, it should also have a predefined threshold, and it should be performed in all participants. And the interpretation of the reference standard should be independent of the results of the index test. And the time between the index test and reference test should be sufficiently short so that it doesn't affect the stage of the disease. And analysis, all participants should be included in the analysis, and unit of analysis should be appropriate. An appropriate method should have been used to calculate estimates of accuracy. So if we were to do this study to find the diagnostic accuracy of this AI-based chest X-ray interpretation, how would we design the study? So we'll be recruiting participants consecutively, irrespective of their symptoms, irrespective of their age, and irrespective of, but pregnant population cannot be included because they should not be subjected to radiation. And all participants should undergo both the AI-based chest X-ray as well as the sputum testing. Sorry, sir.
Pregnancy.
The risk is low, but
I will repeat the question for that.
so can we do a chest X-ray for a pregnant patient if there is a significant disease which requires the patient to undergo chest X-ray? Most of the studies have not shown any harm in subjecting a pregnant patient to an X-ray. But considering these patients are relatively asymptomatic, free of disease, it might not have been ideal to do a chest X-ray for 50,000 participants. So index test should be a latest version of this QXR tool, and it should be blinded to the reference test results. The target condition, what would have been ideal, should be a composite reference standard, which includes both clinical and microbiological data, including expert and MJIT culture results. An analysis should have included all the cases. And assessment should have been done for sensitivity, specificity, likelihood ratios, and predictive values. So next we'll be seeing whether our study also followed this same principles, and we'll be looking at how it differed from the ideal test accuracy trial. So the study had calculated an estimated sample size of 316 expert positive patients based on an assumed 80% power to detect a 3% difference in sensitivity in between universal and age sex determined CAD thresholds, with a significance level considered to be 5%. So this is the flow diagram of the study, which we generated based on the details provided in the study. Around 54,840 participants were assessed for eligibility, and around 2,000 of them were excluded for various reasons, which include them being on TB treatment, which was 77. 12 of them did not provide consent. 1,374 of them were pregnant, and 542 participants did not have a valid X-ray result. So after exclusions, about 52,835 participants received a CAD interpreted chest X-ray. And among the 52,835 participants, 43,000 of them had a CAD score of less than 0.1. And 8,949 participants had a CAD score of more than 0.1. One thing unusual was that those who had a CAD score of less than 0.1, the study authors did not do a expert testing on these participants who had a CAD score of less than 0.1, and they had assumed prevalence in these participants to calculate sensitivity and specificity. Anybody, irrespective of symptoms, they are eligible. They should not be on tuberculosis treatment, and they should not be pregnant. And around 8,949 participants had a CAD score of more than 0.1, in which around 8,038 participants were offered sputum testing, and 7,200 provided sputum. And in this, 20 of them had invalid sputum results, and 7,219 of them had valid sputum results, and 382 of them were expert positive. The rest of them were expert negative. So these were the baseline characters of the study participants. The median age of participants included in the study was 38 years, and it was more of females than males, which included 55%. And 6.6% of the participants were HIV positive, and 48% were negative, and 44% did not report their HIV status. 1.4% had received tuberculosis treatment in the past, and 4.2% were active smokers, and 43% of them had reported any one of the 4 usual symptoms of tuberculosis, which included cough, fever, night sweats, or weight loss. So phase 4 requires us to find the numerical accuracy estimates for each of the estimates in the study and assess for risk of bias and applicability. So the first estimate that I found from the article was the overall diagnostic accuracy at high sensitivity threshold, with the index test threshold being 0.1 as per the study. The reported sensitivities and specificity for the threshold of 0.1 was 89.9% and 83.6%, with an AUC of 0.92. They had also done another primary outcome analysis, which included stratified age and sex specific stratified analysis to see whether age and sex stratified analysis will improve the sensitivity and specificity. And they had found that the sensitivity and specificity was 2% higher if they had used an age and sex specific threshold. For want of time, I will not be going into the details of the age and sex specific thresholds. If the viewers would like to have a look at the details of this, they can look at the supplementary appendix attached to the article. Which one, sir? That I'm coming in the subsequent slides. So next we'll be assessing the risk of bias under individual domains. The first domain will be assessment of participants. The signaling questions. The first signaling question will be, was a single gate design used? Single gate design means that all participants in the study were passed through the same set of eligibility criteria before they were enrolled into the study. For this, I have given an S because all participants are subjected to the same eligibility criteria. The problem with multi-gate design is that participants have enrolled in the study based on different eligible criteria, like for example, cases and controls. And when we have a multi-gate design, the problem is that there can be a possibility of spectrum bias, wherein the entire spectrum of participants with the entire spectrum of disease will not be represented in the study population. But here, the authors have used a single gate design. And whether participants prospectively enrolled, I have given a yes to this question because they have prospectively recruited participants between June 2022 to March 2024. And have they used a consecutive or a random method of sampling of participants? I have given no information for this question because the study does not clearly state as to how exactly they were recruited. The participants have been mostly recruited from the community setting. Like, for example, they have set up testing tents near healthcare facilities. They have been recruited from areas of high traffic. They've been recruited from, and they have also recruited companions of the patients, staff, and whoever passed by. They have interacted with participants who are passing by, and it looks from what they have described, it appears that they have probably used a convenient sampling. And is the study group a representative sample of the intended use population? I would give a probable yes, though it would have been ideal to have included even children, those who are less than 15 years. They have included probably a large sample size and about 50,000 participants, and they have included both symptomatic as well as asymptomatic participants, which is an ideal setup for a screening study. So overall, considering the all the signaling question answers, I have given a risk of bias for the participant domain to be low. And the second section under participant section is concerned regarding applicability. For a systematic review, this will be given based on the systematic reviews synthesis question. But here we have used only a single study. So we'll be looking at what would have been the ideal in real world scenario, how would it have been, whether this would have been applicable or not. So if we had to do the screening test in our population also, we'd be probably expecting a similar age group of participants, though the HIV incidence might have been relatively lower in our population than compared to their population. And probably a higher number of participants might have received TB treatment as compared to the ones described in the study. But overall, I feel in the real world scenario, it is not likely to be grossly different from what has been used in this study. So I've given a low risk, low concern for applicability. So the second domain will be assessment of the index test, and the signaling will be looking at the individual signaling question. The first signaling question will be, was the index test conducted and interpreted according to the recommended instructions? For this, I have given a probable no because the manufacturer recommended threshold for interpreting the chest X-ray to be positive was 0.5, whereas the study authors had determined that even those who had a score between 0.1 to 0.5 still had a 1% risk of being expert positive. They subsequently, at 4 months, decided to lower the threshold to a 0.1 to improve the sensitivity based on other prevalence studies as well. So I have given a probable no to this question. So this was how the flow of the study was. Non-pregnant participants were offered screening using portable chest X-ray in the community. And the chest X-ray was fed to the AI-based chest X-ray interpretation tool, which is called as a QXR version 3.2, which assigned a TB score ranging between 0 to 1. Those who had a score of more than 0.5 initially, and after 4 months, those who had a score of more than 0.1 were subjected to sputum testing using the Expert Ultra. And those who had a score less than 0.1 were not subjected to further testing. And in this group of participants, the prevalence of TB was assumed to be 0.1% for analysis purpose. So the second question is, was the index test results interpreted without the knowledge of the reference standard? The index test being AI-based chest X-ray interpretation, it did not require any of the patient characteristics, patient symptoms to be entered, nor did it require information about the reference standard. So for this, I have given an S. And the third question, was the index test results interpreted with the same information as that would be available when the test is used in practice? Even when we use the test in practice, this test does not require any of the clinical details or any data to interpret it. It just needs a portable X-ray. So I have given an yes to this question as well. So if the index test threshold was used, was it standard or pre-specified? For this, I have given a no, because they have not pre-stated a clear-cut threshold before they began the study, and halfway through the study, they have changed the threshold from 0.5 to 0.1. So because one question was given a probable no and another question was given no, the overall risk of bias for this section will be taken. I have given a high risk of bias. So concerns regarding applicability, even in the real world scenario, I don't think there will be a difficulty in conduction or interpretation of this chest X-ray, because it doesn't require any human input or anything. It is completely system dependent interpretation of the chest X-ray. So the third domain will be the target condition and assessment, which is pulmonary tuberculosis. How was the target condition assessed? The authors here had chosen expert ultra status as if they were expert ultra positive, they have been taken as disease positive, and if they were expert ultra negative, they have been taken as disease negative. And what was the time interval between the index test and reference standard? The authors have mentioned that those who had tested positive on the AI-based chest X-ray interpretation were subsequently asked to give a sputum sample for expert ultra, but they have not clearly told us to what was the median time duration between the chest X-ray and the participant giving the sputum sample. So the reference standard used here was expert ultra from the expectorated sputum. But in this study, they have not used any sputum induction methods, or there was no culture test performed in this study. And with regards to interpretation, the expert ultra gives values as either positive or trace positive or negative. In the primary outcome, the authors have decided to include positive as well as trace positive results as overall positive. Because expert ultra is highly sensitive, even it can detect bacillary load as less as 15 per high power field. And usually in the clinical scenario, we take into account the patient symptoms and presentation in the clinical scenario before we take a trace positive as positive and decide to treat the patient. So coming to the domain of target condition, the first signaling question will be, does the reference standard adequately identify those with and without the target condition? This I have given a partial yes, because though expert ultra alone will not necessarily pick up all the pulmonary tuberculosis patient, that could be that they could have possibly missed patients because they did not use induced sputum testing, and they did not subject the sample to culture testing also. And was the target condition assessed in all the participants? For this, I have given a no, because only participants who had a CAD score of more than 0.1 were subsequently asked to give a sputum sample. And around 83% of the participants had a score of less than 0.1, and they did not receive a expert ultra testing. So in this group of participants, they had assumed a TB prevalence of 0.1%, and they had done multiple sensitivity analysis, assuming prevalence ranging between 0.05% to 0.3% to calculate sensitivity and specificity. So this is the graph showing X-ray scores on the x-axis and proportion of screen participants on the y-axis. Here we could see that around 43,886 participants had a score less than 0.1, and they did not receive a sputum testing. So what is a problem if all the participants do not receive the reference standard? Here there is a possibility of the introduction of a partial verification bias, wherein the participants who are negative on the index test are labeled as disease negative and sent home, whereas we could have probably missed some cases because we label them as negative just based on the index test. And because the false negatives, there's a possibility of there being false negatives. And the problem with partial verification bias is that it overinflates the diagnostic test sensitivity and brings down the test specificity. And one another example is like using a stool occult blood as a screening test for diagnosis of colon carcinoma and using colonoscopy as a reference standard. If, for example, if they are negative on the stool occult blood, and if we decide to label them as not having colon carcinoma, there's still a possibility that we are missing out on CA colon cases. And this will falsely elevate the test sensitivity and bring down the test specificity. And was the target condition assessed in the same way in all participants? For this, I've given a no, because the target condition was assessed differently in those with different CAD scores. Because in those with higher CAD scores, they underwent sputum testing, and based on expert status, they were labeled as having or not having tuberculosis. Whereas in those with a CAD score of less than 0.1, prevalence was assumed. And did the reference standard avoid incorporating the index test? For this, I have given a yes, because the microbiologist who had interpreted the expert ultra testing did not have details about the CAD test results nor about the patient's symptoms. And the fifth signaling question will be, was the reference standard conducted and interpreted according to the recommended instructions? I have given a yes to this question. And was the reference standard results interpreted without the knowledge of the index test results? Again, I have given an yes to this question. And if a reference standard threshold was used, was it standard or pre-specified? For this, again, I've given a yes, because they've pre-stated that they will interpret trace positive and positive to be having tuberculosis prior to doing the test. And was there an appropriate time interval between index test and reference standard? They have not clearly mentioned as to what was the time duration between the patient undergoing a CAD test and giving a sputum sample. So overall, the risk of bias, I have given a high. So coming to the section on concerns regarding applicability, if we had to, in the real world scenario, like for an example, in Indian setup, we had to do a similar study. Will we be doing the same reference standard? Probably yes, because if the screening population is so large, it will be difficult to subject each of the participant sample to culture testing and induced sputum testing. So it will be more pragmatic to use the expert ultra testing rather than the culture result as well. So I have given the concern to be low for the target condition defined by the reference standard of expert ultra. So the fourth domain that we'll be looking at is the analysis domain. And first question will be, describe any participants who are enrolled in the study but excluded from the 2x2 table. So I'm coming back to the flow chart. Here we could see that in the 2x2 analysis table, around before inclusion into the study, around 2,000 participants were excluded for various reasons, which we had seen previously. Like, for example, because they were on TB treatment, because they did not provide consent, because they were pregnant, and some of them did not have a valid X-ray result. And
Normally, when you do a study,
we would expect
30, 40, 50, on the beaches.
There feels that it's very unlikely that just 12 participants refuse consent among 54,840 participants who are eligible. That seems fair, sir. And how was any missing 2x2 data, including missing reference standard data, accounted for? Here we could see that around 8,949 participants who had a CAD score of more than 0.1 were offered sputum testing, but subsequently only 7,219 of them had valid expert results. The remaining participants, there's no clear reason as to why they have not been able to interpret these results. And in the final analysis, this around 1,700 of them were excluded, and only the 7,219, this number was only included in the final analysis. So overall, around 19.3% of the participants in the CAD score of more than 0.1 arm did not receive expert testing. And overall, 86.33% of the participants among the 54,000 did not receive an expert testing, which is the reference standard, which is significantly high. So the missing data included invalid sputum results for 20 participants, and 542 of them did not have a valid X-ray result, which was excluded in the final analysis. So did they use any additional non-standard statistical analysis? They have done multiple sensitivity analysis using difference prevalence assumptions, and they've also used model TB prevalence in the untested participants as well. And coming to the fourth domain of analysis, that all participants included in the analysis, that I would say probably no, because many of them who had improper X-ray result, improper sputum results were all excluded from the analysis. And was missing data handled appropriately? Again, I would give a probable no. And does the unit of analysis match the ideal test accuracy trial? For this, I have given a yes, because participant was the unit of analysis. And were the estimates of sensitivity and specificity calculated appropriately? Because they've used a modeling, they modeled the prevalence for those with a CAD score of less than 0.1, and around 1,700 of the participants did not have a valid expert results. I have given a probable no to this question. So the overall risk of bias for the analysis section is high. So next we'll be constructing a 2 by 2 table based on the data available from the article. They have stated that the X-ray score of 0.1 was 43,886 participants, and those who had a score of more than 0.1 were 8,949. Assuming that the prevalence of tuberculosis among those with the X-ray score of 0.1 to be 0.1% of 43,882, it comes to about 44. And 382 were expert positive among those with a CAD score of more than 0.1. Based on this numericals, if you put a 2 by 2 table, this is the numbers that we arrive at. So let's try calculating the measures of diagnostic accuracy, which include sensitivity, specificity, predictive values, and likelihood ratios. So just a small recap about tests of diagnostic accuracy. Sensitivity defines how likely is a test to identify all those who have a disease. And the mnemonic is for sensitivity is SNOUT. A highly sensitive test, if negative, effectively rules out a disease. The formula to calculate sensitivity is true positives among those who have the disease. And would anyone like to calculate the sensitivity for this 2 by 2 table? Yes. 89. So the sensitivity as per this 2 by 2 table was 89.7%. And specificity is the ability of a test to correctly identify those without the disease. And the mnemonic for specificity is SPIN. A highly specific test, if positive, rules in a disease. So the formula for specificity is true negatives among those without the disease. And can someone calculate the specificity based on this 2 by 2 table and let me know? Yep. So it was 83.6%. So next, coming to predictive values, the positive predictive value is nothing but if a test comes positive, how more probable it becomes for the patient to have the disease. And this is calculated by the formula of true positives among those who test positive. So would someone like to tell me the positive predictive value for this 2 by 2 table? %4. So the positive predictive value was 4.2%. And negative predictive value is if the test is negative, how less likely it is for the patient to have the disease, which is calculated by the formula of true negatives among those who test negative. And the negative predictive value for this 2 by 2 table was 99.8%, which was quite high. So likelihood ratios, we have the positive likelihood ratio is nothing but for a defined pretest probability. When we apply the likelihood ratio, how more likely does the test condition becomes possible. A negative likelihood ratio means how less likely the test becomes possible after applying the value. The formula for positive likelihood ratio is sensitivity by 1 minus specificity. Would someone like to tell me what is the positive likelihood ratio for this study? The formula is sensitivity by 1 minus specificity. 5. And the the positive likelihood ratio was 5.4 and the negative likelihood ratio was 0.1. Test is said to have a very good likelihood ratio if it's more positive likelihood ratio if it is more than 10, and it is told to have a good negative likelihood ratio if the number is less than 0.1. So this was matching to the results as shown in the study. For an assumed TB prevalence of 0.1% with an X-ray threshold of more than 0.1 to be taken as positive, the sensitivity was 89% with a specificity of 83.6%, with an AUC of 0.92. These were other sensitivity analysis done for varying X-ray thresholds and varying assumed TB prevalence scores. They have looked at other studies in Uganda which assumed TB prevalence and it was 0.1. So in this study, they had assumed the TB prevalence to be 0.1. So domain 6 gives an overall estimate about the risk of bias. For this, I have given a color coding using the RoBWIS risk of bias visualization tool. And for this study, for domains of participants, the risk of bias is low, whereas for the domains of index, test, target, and analysis, the risk of bias is high. Hence, the overall risk of bias is high. And for applicability concerns for participants, index test, and the target condition, I have given a low risk of bias. Hence, the overall applicability concern is low.
So when take five, if you want to going back to epidemiology, the condition where population prevalence is 0.1%, this exercise a good tool to good screening to be taken over. The primary percentage, plot. So if by subject people do an exercise, you are not going to reject this thing. First, we like to move the purpose. I mean, I know we have, then this is not a learning process of the algorithm, right? Learning process.
Yes.
Already. Learning process, yes, okay. Like you already learned a movie, then use it in the hour. But no, as a 0.1%, your cost for 2 weeks would be easily far more easier than the applicable than I feel, or even on that basis, the applicability is, and they change the word first in between. So, did they go back and call all the people who are 0.125 and okay.
They have not accounted for that group of.
By that time. Did they use put them in all those patients, even at 6 months? How many years did they study?
22 months was the overall duration of the study, and 4 months into the trial, they had changed the threshold.
Even if the 5,000 patients would have been
Yes.
state of that this one they did not have a settlement. So that's why you that phase one, I think the bias is very high. Summarize Sir's comments.
So Sir feels that even in the applicability concerns, the overall risk of bias will be still high because they had changed the threshold halfway through the study from 0.5 to 0.1, and it would not be appropriate to subject such a large population to a chest X-ray, given that there are other alternative options available, which includes sputum testing. So next, coming to cost effectiveness of this new diagnostic accuracy study. The study per se does not give any details about the cost effectiveness of this new diagnostic study, but we have looked at other articles which use this same diagnostic accuracy study and looked at what was the cost effectiveness. And in one study published in India, funded by the Ministry of Health and Family Welfare, the incremental cost effectiveness ratio for QXR based tuberculosis screening was minus 9,865, plotting it on the southeast quadrant of the cost effectiveness plane. So those of you who are new to the cost effectiveness plane, this is an cost effectiveness plane wherein the x-axis shows the effectiveness of the new treatment and y-axis shows the incremental costs associated with the new test. A test is considered to be acceptable if it is in the northeast quadrant within the ceiling cost effectiveness, or if it is in the southeast quadrant. Test is not considered appropriate if it is in the northwest quadrant, and in some scenarios it might still be appropriate if it is in the southwest quadrant. Suppose the screening test has a significant cost benefit. So here in this Indian study, the incremental cost effectiveness ratio comes in the southeast quadrant, saying that this diagnostic study was cost saving. But this study authors per se have not assessed the cost effectiveness in this scenario. So again, coming back to the likelihood ratios that we calculated for our study question, we'll try plotting it on the Fajan's nomogram to seeing how it changes the post-test probability based on the likelihood ratio. So for scenario A, if you could remember, was a 45-year-old participant without any symptoms who was just attempts a screening camp to get herself screened for tuberculosis. So what would you expect the pre-test probability of this participant having tuberculosis to be? Okay. Lesser than that, maybe like 0.1 or 0.5%. So I've assumed it to be 0.5%, and using a likelihood ratio of 5, the post-test probability was around 4%. And plotting it for the negative likelihood ratio, suppose the CAD-based test X-ray interpretation comes negative, the negative likelihood ratio was 0.1. So the post-test probability of this disease becomes lesser than 0.1%. So this shows that the study has a very good negative predictive value. So next, coming to the second scenario was a participant who was HIV positive, who had come with 3 months history of cough, fever, night sweats. So what do you think would be the pre-test probability of this patient having tuberculosis? Sorry. 20%. 60. So I also assumed it to be 70%. At 70%, using a positive likelihood ratio of 5, the post-test probability became around 94%. And at 70%, if the test had come negative, taking the likelihood ratio to be 0.1, the post-test probability was still 20%. So this would not really change the management of this patient. So if at all this study had to be used practically, I would say in the community-based setup where someone doesn't have any symptoms and who comes for opportunistic screening, if the diagnostic accuracy test, which is the AI-based chest X-ray interpretation, comes negative, it might, I will not offer expert testing for the patient and will say possibly that this patient does not have tuberculosis. So thank you. I'd like to acknowledge Tambu sir and Vignesh sir for helping me with the presentation.